Welcome back to this next video in which we are studying headaches. Okay, so we've now finished the story of the pathogenesis of migraine headaches, and I now want to move on to discuss the treatment for migraine headaches. So, we'll just go to the side here, and I will put a title here. So we're now going to discuss the treatment for migraine headaches. Now, just as when we were discussing the treatment for tension-type headaches, we divided the treatment up into two separate categories, namely abortive treatments and prophylactic treatments. We will do that here as well. So remember, abortive treatments are the treatments that you take when you're actually suffering from the headache and you need relief from it there and then. So when you've actually got a migraine headache currently and you want relief from that, you want it to go away, you want the pain to go away, then you take an abortive treatment. The prophylactic treatments are the treatments that you take on a regular basis, on a daily basis, to try and prevent yourself from suffering from migraine headaches. Whereas you don't take the abortive treatment on a daily basis, you just take that when you actually need it. So, we will begin then by discussing the abortive treatments first. So I will just put that as a little subtitle here, so abortive treatments. So let's make a little list of the abortive treatments for migraine headache here. So the first two examples that I'm going to put here are drugs that we've already seen before because they were used as abortive treatments for tension-type headaches as well. So the first category of drugs is the NSAIDs, the non-steroidal anti-inflammatory drugs. And hopefully you can remember the 5 examples of non-steroidal anti-inflammatory drugs that I gave you earlier on. So remember, ibuprofen and aspirin are the two most famous examples, but then there's also diclofenac, indomethacin, and naproxen. They are the 5 major examples of NSAIDs. So they're going to be used as abortive treatments for migraine headaches as well as for tension-type headaches. And then, the one that we'll put alongside the NSAIDs, but which is not an NSAID, remember, is of course paracetamol, also called acetaminophen. Okay, so NSAIDs and paracetamol, we've seen these are abortive treatments used for tension-type headaches. They're also abortive treatments used for migraine headaches. Now remember what we said was the mechanism of NSAIDs and paracetamol. They were going to stop the production of prostaglandin E2. And for NSAIDs, we know the exact mechanism by which they reduce the production of prostaglandin E2. They inhibit the cyclooxygenase enzymes COX-1 and COX-2, which are responsible for converting arachidonic acid firstly into prostaglandin G2 and then into prostaglandin H2. And remember, prostaglandin H2 is the precursor prostaglandin for producing all the other prostaglandins, including prostaglandin E2. So if you block the conversion of arachidonic acid overall into prostaglandin H2, then you're not going to be able to make any prostaglandin E2. So that was the mechanism by which the NSAIDs blocked the production of prostaglandin E2. Paracetamol, its mechanism was more controversial. We believe that it, like the NSAIDs, blocks the production of prostaglandin E2, which is how it's so effective at helping with inflammatory pain, but we don't really know how. We thought we'd worked it out when we found cyclooxygenase-free, COX-free enzyme, which paracetamol blocks very, very well. However, the COX-free enzyme let us down. It's not expressed in the right tissues, really, to actually justify paracetamol's effect. So it's controversial how paracetamol actually achieves its effect, but we still overall think that it probably blocks the production of prostaglandin E2 somehow. Okay, so both of these drugs, remember, block the production of prostaglandin E2. How is that going to be helpful in aborting a migraine headache? Well, for that, we need to go back over here to where we discussed the vicious spiral of the migraine headache. So remember, I can't have the whole thing in view at once, but never mind. Remember, when cortical spreading depression initially activates the meningeal nociceptors, they release the mediators of neurogenic inflammation, substance P and calcitonin gene-related peptide, which cause the release of histamine and prostaglandin E2 into the extracellular fluid here. And these then, long after the cortical spreading depression has stopped activating the meningeal nociceptors, these are the things then activating the meningeal nociceptors and maintaining the migraine headache. And this gradually spirals on and downwards in a vicious spiral. Now, if we take an NZ drug or paracetamol, this will hugely reduce the amount of prostaglandin E2 being produced over here, and therefore that will hugely reduce the amount of meningeal nociceptor activation that there is, and therefore we will hugely reduce the release of neurogenic inflammatory mediators, and therefore the entire spiral is contracted down. So it might have been a spiral this size before. After you take the drug, it will be instantly move down to a much smaller spiral, and it will therefore end much sooner. So you'll terminate the migraine headache much sooner if you take an NZ or paracetamol, because you're reducing the production of prostaglandin E2, which is one of the molecules involved in maintaining that vicious spiral of nociceptor activation. Okay, so I hope that justifies for you how the NSAIDs and paracetamol can be effective in aborting migraine headaches. Okay, so we previously saw those drugs, so those are not new ones, and they're not particularly interesting for us. We're now going to see some new classes of drugs that are used to abort migraine headaches, but aren't generally used to abort tension-type headaches, and they would be effective in aborting tension-type headaches, but generally tension-type headaches can be aborted effectively with NSAIDs and paracetamol, so it's not necessary usually to use these drugs, but they can be used to abort tension-type headaches. However, in people suffering from migraine headaches where the NSAIDs and paracetamol are not quite doing the job, they're failing to completely relieve the pain adequately, we can prescribe these stronger drugs. So let's now discuss these stronger drugs. So we'll do this in green here. So the first class of the stronger drugs that I want to discuss are the triptans. So before we discuss the pharmacological action of the triptans, let me recite out a whole bunch of names. So I've got 8 names, I'm afraid, of triptan drugs to give you, and they are all important. They are all still prescribed, so it is important to know their names. So let me list them out here. So this is the boring bit, and you'll just have to bear through this. So the first one to put on here is sumatriptan, probably the most important triptan. Certainly in the UK, sumatriptan is the most commonly prescribed triptan. And by the way, all of the triptans, within their name, the suffix is triptan, so it's very easy to tell whether a drug is a triptan or not. So sumatriptan, another one, elatriptan, and now they're not in any particular order, they're just the order that I can remember them in. So sumatriptan, elatriptan, zolmitriptan, which one should we have next? Naratriptan I'll put on next. So naratriptan. And then I'll go over here to put the other 4. So more. Avitriptan is another one. The other one that begins with A is almatriptan. Almatriptan. And then we still have rizatriptan and frovatriptan. So it is very nice that their names all end in triptan, and that's why the whole class is called the triptans. So rizatriptan, and then finally frovatriptan is the 8th one that I know. Okay, so they are all important, they're all within this category called triptans, and they all have the same pharmacological profile. They're all going to work on the same receptors. Okay, so there's the boring bit, there's their names out of the way. Now let's discuss the actual pharmacological way in which they work. So all of these drugs are agonists at certain serotonin receptors. So we have discussed the neurotransmitter serotonin. We've discussed the fact that there are very few neurons in the brain that actually release serotonin. They have their cell bodies in the raphe nuclei, but remember, the raphe nuclei send out axons all over the brain, so that serotonin is being released all over the place. So you find serotonin receptors all over the brain, and indeed we're going to actually find it in the meningeal nociceptors as well as in the trigeminocervical complex. Okay, so for serotonin, there are many different receptors, a huge number of different receptors for serotonin. The ones that are going to be activated by the triptan drugs are the 5-HT, and remember 5-HT stands for 5-hydroxytryptamine, another name for serotonin, 1B, 1D, and 1F receptors. So this is not just one type of receptor, it would be a very extravagant name for a single serotonin receptor. I'm talking about 3 receptors here. There is a receptor called the 5-HT1B receptor, there is a receptor called the 5-HT1D receptor, and there is a receptor called the 5-HT1F receptor. And all of those receptors are going to be activated by the Triptan drugs here. So we describe the Triptan drugs here. If you want a nice little sentence to describe the pharmacological profile of the Triptan drugs, you can call them 5-HT1B, 1D, and 1F agonists. Okay, so a little bit of pharmacology then. All of these receptors, the 5-HT1B, the 5-HT1D, and the 5-HT1F receptor, they are all G protein coupled receptors. So if I want to draw a basic picture of them, I'll do it here. So here is the phospholipid bilayer. So we have the outer leaflet of the phospholipid bilayer and the inner leaflet of the phospholipid bilayer. And remember, all G protein coupled receptors, they're a single polypeptide, and this polypeptide has a characteristic membrane spanning topology consisting of 7 membrane spanning alpha helices like so. So here's the N terminus, here's the C terminus. So the N terminus is extracellularly, the C terminus is intracellularly, and the polypeptide spans the membrane 7 times. And when it's spanning the membrane, those are alpha helices that are spanning the membrane. So this is an example of a G protein coupled receptor, a GPCR. So the ligand binds to the GPCR changes shape, and then it will interact with heterotrimeric G proteins on the intracellular aspect to convey the signal forward, and those the heterotrimeric G proteins will then cause all sorts of cascades inside the cell to change the cell's behavior. Okay, and we're not going to go into the intracellular cascades, that's a little bit too much detail. Okay, so all 3 of these receptors, the 5-HT1B, the 5-HT1D, and the 5-HT1F receptor, they're all G protein coupled receptors. Most of the receptors for serotonin are G protein coupled receptors. The 5-HT3 receptors are the only exception to that, and they are ligand-gated ion channels rather than G protein coupled receptors. But these 3 are certainly G protein coupled receptors. So it's nice to know that these 8 drugs activate these receptors, but how on earth does this actually help to abort a migraine headache? Well, there are 2 mechanisms. One involving the 5-HT1B and 1D receptors, which are present on the meningeal nociceptors themselves, and one involving the 5-HT1F receptors, which are present on the second-order neurons in the trigeminocervical complex. So let's draw a little picture here. So we'll start off by talking about the meningeal nociceptor. So here we go. So this is the peripheral process of the primary nociceptive afferent, and here what I'm drawing for the first time is a nociceptor where I'm not actually just showing the tree as being lines, but I'm actually showing it with cytoplasm inside it and having a thickness. So I'm drawing you a fancier picture than I've ever drawn you of a nociceptor before. So it looks like a sort of tree here, or a bizarre hand is what mine's turning out to look like. Okay, right, so this is the nociceptor here, and this is the axon, the peripheral process of the primary nociceptive afferent, along which action potentials can be generated. Now, in the membrane of a nociceptor, of course, we've been discussing about how there are loads of these nocicensors, which are the actual receptors for noxious stimuli, and which will be activated by noxious stimuli, and which will cause activation of the nociceptor, which will be trying to activate an action potential to fire along the axon here. However, there are also receptors in the membrane of the nociceptor that are inhibitory of the firing of an action potential. And indeed, 5-HT1B and 5-HT1D receptors are examples of that. So I might just put this here. So there we go. There's the classic G protein shape now in that membrane. And the nociceptors, they have in their membrane 5-HT1B receptors and 5-HT1D receptors. So this one here, this could be either a 5-HT1B or a 5-HT1D receptor. Now, when those receptors are activated, what they lead to is inhibition of the nociceptor. They will try and inhibit the firing of action potentials along the peripheral process of the primary nociceptive afferent. So action potential firing frequency will decrease, and excuse me whilst I get rid of the annoying dot there. Okay, so firing frequency of action potentials will decrease if you activate the 5-HT1B and 5-HT1D receptors. In addition, they will also decrease the release of those neurogenic inflammation mediators. So, the release of those mediators, which I'll put up here, calcitonin gene-related peptide was one, CGRP, and substance P, SP, was another, so their release will go down when you activate the 5-HT1B and 5-HT1D receptors on the nociceptor. So, of course, by reducing the frequency of action potentials going up here, that's going to directly reduce how painful the headache is, but also by reducing the release of the neurogenic inflammatory mediators here, you're going to be reducing the spiral, the vicious spiral, so that the headache will terminate sooner. So, this is one of the mechanisms by which the triptan drugs are effective, because the meningeal nociceptors have 5-HT1B and 1D receptors on their surface, and when you take these drugs, they will activate those receptors and inhibit the nociceptor from firing action potentials and from releasing the mediators of neurogenic inflammation, and both of those things are going to help abort headaches. However, there's another mechanism involving the 5-HT1F receptors. Now, the 5-HT1F receptors, they're not on the meningeal nociceptors, but they are on the second-order neurons in the trigeminocervical complex. So I might try and just draw a little bit of this here. So, here, let's say, in yellow here, this is now the central process of our primary nociceptive afferent that has come in from the meninges here. And then let's have in purple, I think, let's have the dendrite then of our second order neuron, which is in the trigeminocervical complex, the ipsilateral trigeminocervical complex. So here is its axon, and remember it's multipolar, so it will have these dendrites coming off like this, and then here is its nucleus. So this is in the trigeminocervical complex. So again, this neuron is deciding whether to fire action potentials along its axon, and it's deciding from how much activation it's getting on its dendrites. So when a lot of neurotransmitters are released onto it, that will be pro it firing an action potential. Now, again, the second order neurons, they have receptors on their surface that are also inhibitory. So let's just put this here. So there is our G protein coupled receptor, and this time it's going to be a 5-HT1F receptor, like so. So that there is a 5-HT1F receptor. So, if you activate this receptor, this inhibits the chance that the second order neuron will fire an action potential. So this inhibits the firing of action potentials. So the frequency with which this will be firing action potentials will also be decreased. So, when you take a triptan drug, not only is it going to affect the meningeal nociceptors, but it's also going to affect those second-order neurons in the trigeminocervical complexes, and therefore, if they're firing action potentials at a lower frequency, then that means that the message going up to higher centers in the brain, going up to the contralateral thalami, will be decreased, and therefore the pain that you will be experiencing will be decreased. So this is one of the major mechanisms by which the triptan drugs are effective at aborting migraine headaches. And indeed, I said that the triptan drugs could occasionally be used to treat tension-type headaches where the NSAIDs and paracetamol are not effective at aborting that headache. This is the mechanism by which the triptans would be effective on that other type of headache, that the second-order neurons in the trigeminocervical complexes have the 5-HT1F receptors on their surface, and when those 5-HT1F receptors are activated, their firing frequency will be decreased. Okay, so these are the two mechanisms of the triptan drugs, one on the meningeal nociceptors, and then the other on the second-order neurons that have their cell bodies in the trigeminocervical complexes. And I hope you understand how this will be effective in aborting a migraine headache. So, Another category of drugs in the abortive treatment of migraine then is the ergot alkaloids, and this is the final category. And we don't actually have to learn any new mechanisms for the ergot alkaloids because they're going to have the same mechanism as the triptans, they're just in a separate category on their own. So the ergot alkaloids. So let me put in the examples of the ergot alkaloids then. So there are two examples of ergot alkaloids, which are ergotamine and dihydroergotamine. And these drugs are still used. They're older drugs used for the treatment of migraine headaches than the triptans. The triptans have sort of come along and replaced them. However, they are still used. You do occasionally see ergotamine and dihydroergotamine prescribed, and they work in exactly the same way as the triptan drugs work. These drugs are also 5-HT1B, 5-HT1D, and 5-HT1F agonists, and therefore they're going to have actions on the meningeal nociceptors by binding to 5-HT1B and 5-HT1D receptors on the meningeal nociceptors, and they're also going to have effects on the second-order neurons in the trigeminocervical complexes by inhibiting their firing by activating the 5-HT1F receptors on their surface. Okay, so the ergot alkaloids work in exactly the same way to abort migraine headaches. Okay, so that then is my discussion of the abortive treatment for migraine headaches complete. We have the NSAIDs and paracetamol, and then we have the triptans and ergot alkaloids. And these ones are stronger than the NSAIDs and paracetamol. They are more effective at aborting migraine headaches than NSAIDs and paracetamol. But ideally, try these ones obviously first because these are less dangerous drugs on the whole than these ones. So if these are effective, you don't want to have to be taking these drugs. Okay, so let's now move on to the other category of treatment for migraine headaches, which is, of course, the prophylactic, the prophylactic treatment. So I'll put this here. We're now going to discuss the prophylactic treatment, the preventative treatment for migraine headaches. So this is a medication that people with migraine will take regularly on a daily basis, and they'll be taking it to try and actually prevent themselves suffering from a migraine headache. So, let's firstly discuss what the big picture of all of these drugs that I'm about to tell you is. And by the way, in this category, there are 4 drugs that we're going to discuss. So let me firstly give you the big picture. Remember, in someone who suffers from migraine, a migraine attack will actually be initiated when cortical spreading depression occurs in a region of cortex of the brain. So, if you're going to prevent migraine attacks from actually occurring in someone with migraine, that drug is going to have to work by reducing the chance that cortical spreading depression is actually going to occur. And this, I'm afraid, is why I'm not going to be able to give you particularly brilliant accounts of the mechanisms of these drugs, because we don't understand the mechanism of cortical spreading depression, and therefore we don't understand what you would have to inhibit in order to reduce the chance that cortical spreading depression will occur. So these explanations are not going to be as nice as the explanations of how the abortive treatments might work. So, let me tell you about the different drugs here, but that's the big picture of what somehow these drugs must be doing. They must somehow decrease the chance that cortical spreading depression will actually occur in the brain of someone who is susceptible to cortical spreading depression. So, we can split the prophylactic migraine drugs into 2 categories. 2 of them are beta blockers, and the other 2 are use-dependent voltage-gated sodium channel blockers. So, let's start off with the beta blockers because they are simpler and I have far less to say about them. So, beta blockers are drugs that inhibit or antagonize beta adrenergic receptors. So, they are antagonists for beta adrenergic receptors. Now, the main 2 beta adrenergic receptors are the beta 1 and the beta 2 receptors, and both of these are G protein coupled receptors, so they have this same basic structure that I've shown here with the 7 membrane spanning alpha helices. Now, beta blockers are going to be antagonists at these receptors. And I'll just write down that key pharmacological keyword. So antagonists. And remember what an antagonist drug does. It binds to the receptor but does not activate the receptor, and it binds in the site where the other drug or the actual natural ligand for the receptor would like to bind and blocks it from binding. So in the case of the beta receptors, beta 1 and beta 2, the natural ligand is either adrenaline or noradrenaline, and there will be a binding site on the extracellular face of each of these receptors. These drugs will bind to that binding site, not activate the receptor like adrenaline and noradrenaline would, so there's no activation of the G proteins, but they block the natural ligand from being able to bind. That's what it means to be an antagonist, and that's what the beta blockers are going to do. Now, when we talk about the beta blockers, and they're a very famous class of drugs, when we talk about them, we split them into two categories, which are the beta 1 selective beta blockers and the non-selective beta blockers. And you can probably guess what the difference between them is. So there are drugs that we call beta 1 selective beta blockers, and these are drugs that just antagonize the beta 1 receptor. So they don't antagonize the beta 2 receptor. They bind to the beta 1 receptor and block adrenaline and noradrenaline being able to bind to it. But they don't do that to the beta 2 receptor. Then the other category of beta blockers is the non-selective beta blockers that will bind to both the beta 1 and beta 2 receptors with equal or roughly equal affinity, and therefore will block both of the receptors to an equal degree. Okay, now the beta blockers that are used as prophylactic treatment for migraine, there are two of them, and one is a beta 1 selective and the other is a non-selective beta blocker. There aren't many beta 2 selective beta blockers. They do exist, but they're not really clinically used for anything, so not many of them exist. So the two major categories of beta blockers are the beta 1 selective and the non-selective beta blockers. Okay, so the example of a beta 1 selective beta blocker that is actually used prophylactically for migraine is metoprolol. And the example of a non-selective beta blocker that is used prophylactically for migraine is propranolol. So those are the two first prophylactic drugs. So those are half of the drugs that I'm going to tell you about already. Metoprolol is an antagonist of the beta 1 receptor. Propranolol is an antagonist of both the beta 1 and the beta 2 receptors. And I'm afraid my explanation kind of ends there. Somehow, blocking these beta receptors, and presumably it's the beta 1 that's most important, because otherwise why would a beta 1 selective one be important? Well, why would it work if it was the beta 2 one that was important? Somehow, blocking those receptors reduces the risk of cortical spreading depression actually occurring in the brains of migraine sufferers. How? I'm afraid I can't give you an explanation of that. It's one of these cases where I can just draw an arrow and say somehow these drugs reduce the chance of cortical spreading depression occurring. I'm sorry that I can't give you any more of a satisfying explanation there. But those two drugs, metoprolol and propranolol, remember, they are examples of prophylactic drugs used to treat migraine. Now, the next two drugs that I'm going to tell you about, I have much more of an explanation to give you here, and it hints at how they might actually be effective at blocking cortical spreading depression. These are far more interesting drugs to be used as prophylactic treatments in migraine. Okay, so the next category of drugs is the use-dependent voltage-gated sodium channel blockers. Now, there are loads of use-dependent voltage-gated sodium channel blockers that are used clinically. It's a very, very important mechanism, and I am actually going to devote a bit of time to explaining how use-dependent voltage-gated sodium channel blockers work. The major example of a category of drugs that is that are use-dependent voltage-gated sodium channel blockers are the anti-epileptic drugs. A huge number of the anti-epileptic drugs are use-dependent voltage-gated sodium channel blockers. And in fact, the two that I'm about to write down for you, they are both anti-epileptic drugs as well as being used prophylactically for migraine. So let me start by writing down their names. So the two that are used prophylactically for migraine are topiramate and also sodium valproate. Now, some of you who know something about sodium valproate might be feeling a little bit uncomfortable at this point, because you might have been told that sodium valproate works in a different way on epilepsy from being a use-dependent voltage-gated sodium channel blocker. Let me address that in just a moment. So sodium valproate, it has lots of different names. This is the first confusing thing. You can just call it valproate, you can call it valproic acid if you really want, or another name that's often used is divalproex sodium. They are all referring to the same drug. Okay, so hopefully if you have heard of topiramate before, you will have heard that it is a use-dependent voltage-gated sodium channel blocker used as an anti-epileptic drug to treat epilepsy and prevent epileptic seizures. Sodium valproate, if you've heard of that one before, you might have been told that the mechanism of sodium valproate is not that it is a use-dependent voltage-gated sodium channel blocker. I guarantee you sodium valproate is a use-dependent voltage-gated sodium channel blocker. It does block voltage-gated sodium channel blockers in a use-dependent manner. However, it used to be thought that that wasn't actually the main mechanism of sodium valproate. It used to be thought that the main mechanism of sodium valproate was that it blocked the breakdown of GABA, gamma-aminobutyric acid, the major inhibitory neurotransmitter of the brain. Now, if you stop the breakdown of GABA, of course GABA goes up in the brain. GABA inhibits neurons firing, therefore you tone down firing of neurons all over the brain. This looks like a very convincing way by which you could reduce frequency of epileptic seizures. However, in recent times, people have been turning their backs and walking away from that theory. And the reason is that the doses that we give sodium valproate at clinically, and which it is clinically effective at, are not sufficient to actually have a profound effect on the amount of GABA in the brain, we don't think, i.e. that mechanism doesn't seem to actually be how sodium valproate can work. So people are now turning back to saying probably actually the main mechanism of sodium valproate is that it is a use-dependent voltage-gated sodium channel blocker. So that is why I have put it under this category of use-dependent voltage-gated sodium channel blockers, because now people are starting to think that probably the clinical effect of sodium valproate is from it being a use-dependent voltage-gated sodium channel blocker rather than it inhibiting those enzymes involved in the breakdown of GABA. It does inhibit them, but does it do it to a big enough level that it would actually produce any clinically noticeable effects? The answer is we think potentially not anymore. Okay, so we're going to class sodium valproate or divalproex sodium as a use-dependent voltage-gated sodium channel blocker. Now, I am going to go into the mechanism by which use-dependent voltage-gated sodium channel blockers work in huge amount of detail so that you completely understand it, because it is a complicated mechanism. It's a very important mechanism. We're going to discuss more use-dependent voltage-gated sodium channel blockers later. We're also going to discuss use-dependent voltage-gated calcium channel blockers. So it's important for us to understand this mechanism. And you know, this is the mechanism by which most of the anti-epileptic drugs work, so it's an important mechanism and it's a beautiful mechanism, but it's a complicated mechanism when you first see it. So we will go into that in some detail, but firstly let me give you the big picture of what these drugs actually do. Let me make you in utter awe of these drugs first, and then I'll explain how they actually achieve this remarkable effect that they have. So let me tell you what they do, and then we'll see how that might link up to blocking cortical spreading depression risk. So these drugs, if you bathe a whole bunch of neurons in these drugs are blocking voltage-gated sodium channels. And one of the key questions you should ask is, why does that not just kill the brain? If we're filling the brain with something that blocks voltage-gated sodium channels, why does that not just stop everything from firing action potentials? And it's this use-dependent bit at the front that is very important. We don't just call these voltage-gated sodium channel blockers. They are cleverer than that. They block voltage-gated sodium channels in this use-dependent manner, and explaining really what that means requires a thorough explanation. But what it means on the grand scale is that actually, if you bathe the brain in these drugs, most of the neurons will continue firing action potentials completely normally. The use-dependent voltage-gated sodium channel blockers, they only block neurons from firing action potentials if those neurons are firing action potentials at a ridiculously fast rate. Okay, I'll say that again. Most neurons are not going to be affected at all. If you are a neuron, and I'm just going to draw a little neuron so that I've got something to point at here. So here is my classic little picture of a neuron. Here are its dendrites coming off here, and here is its axon. So if this neuron is firing action potentials at a normal rate, then bathing it in one of these use-dependent voltage-gated sodium channel blockers will not do anything to it. It can continue to fire action potentials at that normal rate. If, however, you have some neurons in the brain that are misbehaving and are firing at a ridiculously too fast rate, so you've got a neuron firing far too fast, and if you bathe it in this drug, in one of these drugs, a use-dependent voltage-gated sodium channel blocker, it will completely block that neuron from firing action potentials. Not a single one will be fired. If a neuron is being stimulated to fire action potentials at a ridiculously fast rate, it will not fire any if it is being bathed in a use-dependent voltage-gated sodium channel blocker. And that's the reason that these drugs are so powerful in epilepsy, because in epilepsy there is a collection of neurons called an epileptogenic focus that starts misbehaving hugely and starts firing at a ridiculously fast rate and stimulating the rest of the brain to fire at a ridiculously fast rate. And if you are taking one of these use-dependent voltage-gated sodium channel blockers, then that epileptogenic focus will be completely silenced. Because they're trying to fire action potentials far too fast, and they'll be completely blocked. They won't be allowed to fire any action potentials. Whilst the rest of the brain, all of the neurons that are firing at a normal rate, they will not be affected by the use-dependent voltage-gated sodium channel blocker. So that's the genius of these things. They don't block most neurons from firing action potentials. They allow most neurons to continue firing action potentials exactly as they were before the drug. But those neurons that are misbehaving and are firing action potentials far too fast, they silence them completely. And that's why these drugs are incredible, and that's why they're so effective at treating epilepsy. Now, why might this be effective in treating migraine? Well, cortical spreading depression. You get hyperactivity followed by the prolonged underactivity. So, the use-dependent voltage-gated sodium channel blockers, they're going to block that overactivity. So potentially, if you don't have the overactivity, maybe you don't get the underactivity following it. Potentially. Anyway, maybe the underactivity follows from the hyperactivity, and if you block the hyperactivity, which indeed these drugs will do, maybe that then blocks the underactivity as well, and somehow maybe that prevents the propagation of cortical spreading depression. I mean, it kind of doesn't quite work, because we've said previously that it's probably caused by something diffusing, but potentially this could be a hint as to the mechanism, because we did say that the actual pain, the activation of the meningeal nociceptors, that isn't necessarily caused by the same chemical mediator that is causing the excitation. So potentially, if you give a use-dependent voltage-gated sodium channel blocker, this potentially blocks the strange function of the neurons. The chemical mediator might still be there, it might still be spreading out over the brain and trying to cause cortical spreading depression, but if you don't get the hyperexcitability because of the use-dependent voltage-gated sodium channel blocker, then maybe you don't get the depression, and then maybe you don't get the release of some of the mediators that then cross over to the meninges and trigger the activation of the meningeal nociceptors. And of course, everything that I'm saying here is maybe, maybe, maybe. Potentially, this is giving us a hint as to the way that cortical spreading depression works, and the way these drugs work to prevent cortical spreading depression, actually giving rise to an aura and giving rise to the activation of the meningeal nociceptors. Okay, alternatively, you have to remember that the meningeal nociceptors, the primary nociceptive afferents that are attached to those meningeal nociceptors, they might be firing action potentials at an extremely fast rate once the nociceptor has been activating them. So potentially another way that this could work is by actually silencing the primary nociceptive afferents, which are firing action potentials at a very fast rate. Who knows? But we think on the whole it probably actually stops the cortical spreading depression, because it stops the aura as well as just the migraine headache. Okay, so the use-dependent voltage-gated sodium channel blockers, they work by stopping, silencing neurons that are firing action potentials at a far too fast rate. Now, in the next video, I will explain to you the mechanism by which these incredible drugs are believed to actually succeed in only silencing neurons that are firing action potentials at a far too fast rate and not silencing all the other neurons. And this will involve a little bit of background. We'll have to really properly understand the action potential. So not meaning to patronize my viewers, but I will be going over the action potential just so that we've got it fresh in our minds. We'll also need to understand the activation and inactivation of the voltage-gated sodium and voltage-gated potassium channels, and then we will be able to discuss how these drugs work. And it is a beautiful mechanism. Once you understand it, it's incredibly satisfying, and it's an incredibly important mechanism because it's the way that most of the anti-epileptic drugs work, including these ones that we're studying here, topiramate and sodium valproate, that are used prophylactically for migraine. And we will see other drugs that have the same mechanism that are used later on for other causes of headaches. So I'll see you in the next video for that fun bit of pharmacology.